Welcome, and thank you for joining us today for the Better Health Governance, Better Health, Harnessing the Evidence webinar. My name is Alina Sims, and I am a communication specialist with USAID's Health, Finance, and Governance Project. Before I hand it over to our moderator, Bob Fryatt, I wanted to go over a few housekeeping items. We are using WebEx as our webinar platform. You can join either via telephone or the web. If you are having difficulties hearing, you may want to switch your audio option via this quick start menu. The WebEx platform also has two interactive features we'll be using, the Q&A and chat. The buttons for these features are in the top right-hand corner of the WebEx window. You can use the chat panel to interact with fellow participants or if you're experiencing technical difficulties. For any technical difficulties, please send me a message at either host or to Alina Sims, and I will work to help you address your issue. Please use the Q&A feature to ask any questions that you may have. We will take time for questions towards the end of the webinar, but we encourage you to submit questions as they arrive. Please note that this webinar is being recorded and will be available soon afterwards on the HFG website. I will now hand it over to Bob Fryatt, HFG's Project Director, to get started.
Thank you, Alina. Good morning, afternoon, and evening. My name is Bob Fryatt. I'm the Project Director for the USAID Health, Finance, and Governance Project, and I'd like to introduce the speakers and then say a few opening comments. So today we have our first speaker, David Jacobson, who is a Democracy Specialist at USAID's Center of Excellence on Democracy, Human Rights, and Governance, where he focuses on issues of cross-sectoral integration of democratic governance, local capacity development, systems thinking, and applied political economy analysis. He's here today speaking in a personal capacity. Then we have Boluwati Flolodare, President of Chestrad Global Development Initiative, an African-led social enterprise where she works to positively disrupt traditional norms of development financing, focusing on not only financial inclusion for women and young people, but also expanding domestic resources for health and development from corporate shared value, community giving, and organized philanthropy. And then our third speaker today is Courtney Tolmie, who's a Senior Program Director for Results for Development and leads the organization's governance and citizen engagement practice area. Since 2013, she has led several core projects at the intersection of governance and health, including as a principal investigator for the Transparency for Development program, managing and co-leading program design and research that seeks to answer the question of whether community-led transparency and accountability can improve health outcomes and in what context. So just a quick word about the initiatives that will be, and this subject matter. Many of us know that governance is a central component of improving health and health services, but in the past, the evidence base has been confusing or not seen to be very strong. So in 2016, the USAID and the World Health Organization launched an initiative called the Marshalling the Evidence for Health Governance, Contribution to Health Systems Performance and Health Outcomes. USAID and WHO launched an initiative with many other partners, and it was coordinated by the Health, Finance, and Governance Project. The overall goal was to increase the awareness and understanding of the evidence of what works and why in how governance contributes to health systems performance and how the field of health governance is evolving at the country level. 4 thematic working groups were established to consolidate the evidence by conducting literature reviews and key informant interviews from low and middle income countries. It could have focused on many areas, but 4 were chosen. The use of knowledge in health systems, public financial management, policy and regulation, and accountability, which will be featuring later on in the discussion. I'd like to, at this stage, call out some colleagues in WHO who gave us considerable support in this work. In particular, Marianne Begdeli, David Clark, and Deepan Rajan. So thanks to them for their help. The work was concluded at the end of 2017. 5 reports were prepared, 1 for each thematic working group, and 1 that consolidated all the work into 1 report. The work was discussed during the Health Governance Collaborative convened by WHO at the UHC Day in December 2017 in Tokyo. At that meeting, various action areas were decided. One of them, probably the most important, was to have a civil society voice in this area. And this has been the focus for the last 9 months. And this is what we'll be talking about today, and Lola will be coming back to that later on. But to kick things off, I'd like to hand over to David, who's going to go through some of the initial work that the thematic working groups covered over the last couple of years. So David, over to you.
Thanks, Bob, and thanks again to my colleagues at AID, to my other fellow speakers, and everybody who was involved in this research, and to WHO as well for collaborating on taking it forward. So I'm just going to quickly go through a little bit of the process and some of the highlights of findings, and some of the implications that might have for how we think about working on accountability in health. Next slide, please. So in terms of the process, we started with a broad literature review spearheaded by T4d. So Courtney had a front row seat to that. We looked primarily at the health sector, but not exclusively. So a couple studies from other service sectors like education, with a strong emphasis on studies that were empirical, that really had some hard data rather than just modeling or principles. But we did include both quantitative and qualitative data that met certain standards for quality. Most of the works were from the past 10 or 15 years. And then we rounded that out with a tremendously valuable process of speaking with 19 key informants who, as people who live in that space and had done lots of the research and programming around accountability, really had a lot to share with us, and that shaped the report substantially. Next slide, please. So in terms of what we know, accountability is quite a broad and comprehensive term. You'll see if you look at the report that we kind of broke it down into different dimensions of accountability and different theories of how accountability interventions work. But really, when you look for quality studies, it's fairly uneven. Some categories had a good number of studies, and there were some categories of interventions that we know people are working on, but there just hadn't been enough research to say much about it. We were able to say that there is evidence that accountability interventions can matter considerably to health governance, and that under the right conditions, some of the areas where there is a good degree of evidence were around things like increasing access to information, quite a bit around social accountability, things like citizen scorecards or user committees, increasing the effective reporting on health, including some of the horizontal accountability oversight, pay for performance financing, and financial audits. So all of that, I think, is promising news. Next slide, please. I think one of the more interesting things that came out was the inconsistency around topics. So there were a number of studies showing, for example, that some of the social accountability tools were strongly worked in some instances, and findings in the research to that effect. There were also a decent number of cases where it really had not worked. And so it seems to be that where the evidence was pointing us to is that it's not the choice of tool or approach as much as how approaches are carried out, and to some extent how they're conceptualized and why the accountability intervention is going on, that really shapes how successful it is. Next slide, please. And so in terms of what the evidence said about that, we found evidence that accountability interventions were most effective when multiple techniques were used together. So this could be both horizontal and vertical, or this could be different categories of intervention within any of those spaces. Some effort to really tailor them to the social and institutional context where they're being deployed. An emphasis on local dialogue as really contributing often to effective outcomes, and a time period to move from answerability to sanctions. And I should note that we've also just completed a literature review, systematic review actually, in the DRG Center around accountability interventions more broadly, and it found that that this question of timeline as well as kind of building trust and not necessarily starting with a adversarial approach was associated with better outcomes in terms of arriving at accountability and sanctions later on. Next slide, please. So then in terms of how we use this knowledge, some of the tips that came out of both the literature and the key informants of what programmers did who were effective in carrying out accountability interventions. Really taking a structured look at the macro context, things like the political settlement in the country, some of the state-society relations and other aspects, and particularly the power dynamics in that. Something we've been promoting through the use of political economy analysis from the DRG Center. And I think the characteristics of health service is also kind of interesting, that the nature of the service can have a huge impact in terms of the space for accountability, what the frontiers are of what's possible, based on how easily it can be seen and understood by people involved in accountability relationships. And I think as part of that, it's just worth noting that this is something that I think is intuitive and in some ways automatic, often for actors in country contexts who are carrying out these interventions. But we did find that there, and we've found this through our political economy analysis work, that there is some value in actually trying to describe that in formal terms, just to get everybody on the same page around how an effort is meant to work and why it's being tailored a certain way. So it's not so much that it will provide a shocking new insight, but it can help collaboration be more effective and adaptation be easier. Next slide, please. So then also in terms of using knowledge, just a few of the pieces called on us to be mindful that health system actors are part of wider webs of relationships and identities, which is sometimes lost when we are designing interventions to work on the health system as the health system and only view somebody as a clinic worker, district health officer, pregnant mother, and don't think about the rest of who they are and how that contributes to the space for accountability. And then in terms of kind of being strategic and not focusing just on tactics that do or don't work, this idea coming from Jonathan Fox of sandwich strategies over longer time horizons, where you really are trying to squeeze the space for resistance to accountability by doing things that are both with the public and with reformists inside the government, that are kind of locally led and trying to put pressure from all sides so that it's not possible to escape one accountability effort by simply shifting kind of concealment to some other space. Next slide, please. And then finally, I think a couple of the takeaways that I think are really important, especially for any USAID colleagues that I have on the line. We've heard a lot about the importance of iterative approaches that adapt over time and that are built on dialogue, and I think that that is really valuable. And a lot of the examples that we heard in the case studies really built on that. People got to understand, counterparts got to understand the nature of the constraints that different actors in the system had and found ways to demand accountability that really fit that understanding, and that context would shift and the interventions and approaches needed to shift with it. The point on purposes may differ. I think particularly with donor-funded programming, we often find that the donor intention, this money is for this outcome, therefore we want the accountability to describe itself as being about that outcome and to anchor itself to that outcome only, can actually work at cross purposes. Some of the people who might be interested in accountability, including accountability that will contribute to health governance, may not do so because they share the exact same bottom line goals as some of the donors who are trying to address certain specific problems, certain specific diseases. And a more successful effort is going to bring in more of that diversity of voices and not require that they all agree with the donor understanding of why the effort is being undertaken. In fact, it should really be a locally intelligible understanding of why that accountability intervention is necessary, effective, and possible. And this is why really the local interlocutors, which is often either a reformist in the government or in many, many of the cases, civil society organizations, really need to play a key role in leading, sometimes leading from behind, but kind of leading the effort to get accountability efforts, whatever they are, be it audits or scorecards or what have you, to fit and work with the grain of the context. And so I think those were some important takeaways that we had. There were some other takeaways that were more for researchers that I haven't focused on as much. So let me stop there so that we can try and preserve as much time as we can for questions and answers. And I believe I'll hand it on to Lola. Yes, Lola.
Thank you very much. I was very pleased to be a part of this process, and I worked with David on the accountability research. What I'm going to share with you goes well beyond what we did in the technical working group for to look at the good health governance effect. And really working with other civil society networks and organizations to see what we as civil society organizations can bring to bear in promoting what the key researchers found that good governance does make a difference. In doing this, we've also tried to link it to what's going on now, like the movement on UHC, the good governance effect on UHC, good governance effect on UHC, the good governance effect on overall health system, and indeed, how much good governance can help us in multi-sectoral action to achieve the SDG. Next slide, please. We first went back to the standard and historical UHC box, which presented progress in UHC, universal health coverage, from 3 dimensions, and looked at how much impact good governance or effect good governance can have in expanding the 3 dimensions of UHC. This work also looks at the broader context of UHC, and we are trying to also see how messaging and the key messages from the research, especially around accountability, especially around financial management, and also about data use, can be promoted within various networks, including the efforts to revisit UAP primary healthcare at the Astana conference. Good governance enables voices. I think that this is very clear from whatever part of the research you've looked at, from information to public financial management to facility management. Good governance enables voices. And when voices of citizens and communities and end users are enabled, efficiency is the only result. It also contributes to equitable access. So if you look at your cube, you would see that the dimensions include population, that is when citizens' voices are enabled. We looked at social accountability and enabled because it expands the inclusiveness of UHC action. Social accountability enables marginalized and vulnerable populations to be reached and be included in both planning, performance evaluation, and accountability design. On another dimension, inclusive laws and policies, which are actions of good governance, also ensure that it's not just about, we're beginning to move, like David has said, it's not just about data, access to data, but also access to data used for answerability. And so promoting inclusive laws, including freedom of access to information, would also enable us to expand and have effect on population dimension of UHC. One of the key things in UHC, of course, is the cost dimension. The availability of freedom of information laws, participation, inclusion in different networks, and in also voices also mean that the cost dimension requires data access by citizens, civil society, media, and access to budgets. The African Budget Health Network has done a lot of work in promoting access to budgets, but also good governance also means that as cost dimensions, we're also exposed to access to releases, because I'm sure, you know, in many of our lower and middle income countries, the actual part of the budget may not be the same thing as the actual release of the budget. And so good governance and investing in voices in health governance allows us not to have only access to data, but also promote accountability through access to budget. It also reduces waste and corruption. I mean, voices mean that you are able to flag under the table payments. It means that they come to the committee, and you can also find redress in the process. Grievance and redress processes also improve financial management and they reduce corruption and waste. This also means that there is not only decentralization of services, there's also the concentration of power to the communities and district level. This is very important. This is a very important part of good health governance, and we need to bring it back on the table. In the many years I've worked in primary health care, we have talked about deconcentration, decentralization. These terminologies are not new to us, but the evidence helps us. The evidence of the Marshall report helps us to bring them back on the table in the context of primary health care, and also to begin to push for citizens' participation at community level and at their first referral facilities. Service dimension. The cube also looks at how good governance expands the service dimension. This is really about improving alignment of resources, public, private, philanthropic, domestic, international, which is something we at Chester are very, very, very passionate about. Improving the alignment of resource flows is not only domestic, it's also international. It is also about financial management, but it's not just improving, it's also making sure that it's improved around prioritized essential health services and basic system support. And so you can see from that cube that the effect of good governance is multidimensional and it's almost a domino effect on achieving that our current food funds, system strengthening, health security are all achieved. Next slide, please. This process ends with a call to action, and I've just shared that slide, which shows you when health governance is missing. There's a big ambulance in front of an empty clinic. There's a big project. I work in Nigeria, and there's a big project called Saving 1 Million Lives in Nigeria, which is well celebrated, but at the local level, saving 1 million lives is just a poster. And if you look at down there, there is the UNFPA kits. The UNFPA kits are there, but you can see that family planning kits are actually very poorly, the quality of care is questionable at the local level. This is the call to action that we support in good governance. Citizens' voices, citizens' engagement, civil society action that allows this kind of end user experience of quality on access to be brought to the table of policymakers as well as development partners, so that we can be sure that we're tracking what is happening. So the call to action addresses 4 groups of people. Next slide, please. My first slide looks at what can national governments and regional institutions do. Without any doubt, expanding the space for civil society input, access to, and use of data is the pathway to ensuring better representation, equity, and accountability. As we begin to talk more and more on equity, I learned something from this process, the sandwich. That sandwich is very important, because without us looking at the different stakeholders and making sure representation is equitable, we cannot get to answerability. And answerability is global, answerability is local, but we need to start from ensuring the input and data use is important. So governments and donors need to create performance-based financial incentives for health services. Sometimes even this performance can be non-financial, these incentives can be non-financial. We need to have multi-year budgeting and medium-term expenditure frameworks. Many of our frameworks in health do not relate to poverty reduction strategies. And so making sure that our MTFs relate to poverty reduction strategy is one of the things that we're proposing as civil society to be a call to action resulting from this set of studies. Gender-sensitive budgeting improves health outcomes, not only amongst women, but amongst vulnerable populations, particularly where many of their health issues, STDs, HIV/AIDS, maternal and child health have a gender perspective, and so health governance also improves the inclusiveness of these vulnerable groups. Policymakers should consider oversight and audit mechanisms. We begin to chart into the realms of what are the indicators of good governance. I think these are early days yet, and we feel that calling attention to this now and calling for oversight that helps us to develop and track good governance or indicators of overall good governance effect would be the way forward for national health and national governments and regional institutions, particularly in Africa. Next slide, please. We also propose call to action to civil society and non-state actors. In many of our communities, civil society and non-state actors delivery are the closest clients to the people. And so we need to strengthen community input and civil society in these networks and build local capacity. This is not a flash in the pan effect. 40 years after Alma Attas, one of my greatest concerns is that we're still thinking that health systems are bad, health systems are poor, people don't have access. And the last monitoring report reported that more than 50% of the world's population don't have access to services. It's because we need to call actors to invest in the long term. It's not a flash in the pan 3-year policy tumble. It's something we need to invest in the long term. To do this also, our investment in the long term will need for us to have effective feedback loops to communities and households. And the effective feedback loops is not just only about a scorecard. There are also community dialogues. There are also facility-based communities, and it's not just publishing a scorecard. In Nigeria, we have many scorecards. In fact, the plethora of scorecards need to address policy, and they need to get the table of policy, as well as feedback to the communities that action has been taken. And so this is a call to action. But these require tools. They require mechanisms. And they require some degree of capacity building within civil society itself to track performance and promote accountability. Next slide, please. We have the call to action and recommendations, key messages for global initiatives and programs. I'll give you a few examples of this. The NTD Alliance, the SON, the Nutrition Alliance, UST 2030, PHC Strategy Group. There are quite a number of programs that impact on health or social or related sectors that impact on social determinants. At the country level, these come out as fragments. Building and aligning harmonization is very important to good governance and to PHC and UHC. These processes need to establish stronger platforms for mutual accountability with broader and deepened engagement of civil society and communities that go beyond participation at meetings. I must really celebrate the marshalling evidence process. It has taken the effort not only to collect existing data from global databases and research, but also to bring in community perspectives and practitioner perspectives such as mine. It needs to go beyond the research to impact on the processes of mutual accountability. Donors, policymakers need to ingrain an understanding of better health systems governance. It's almost the first time we're bringing in the levers and drivers of accountability, good practice and governance into a title that we're calling health systems governance. It's potentially novel. And so I see this research as the beginning of a journey. That journey needs to also start with the donors. They have significant influence in terms of resource mobilization. So taking this message to the donors, to policymakers, and ensuring that they are embedded into state commitments going forward, investment going forward, I think is a critical role for the global initiatives and programs. Next slide, please. Let me end with our development partners. Development partners is a term I enjoy using because it really just means all of us. But in this regard, I'm focusing on those to whom we look forward to delivering resources to take us forward and to move health into when everybody's covered by a basic package of health services. We need to ensure that governments and donors integrate social accountability requirements into all community health services. 2, again and again and again, we find voices citizens, communities, media, parliamentarians are important part of this. But these have at the moment very, very tokenistic participation on the table. And so one of the messages I think we should be taking to development partners is an investment in meaningful engagement and institutionalization of civil society and non-state action at country and regional levels into financing strategies. Everybody needs to be financed. People need to have their time covered. They need to have their institutional capacity not only strengthened, and this goes well beyond training. So much of what we present here goes to the big question of how do we build community, civil society engagement. It's going to require investment from development partners. It's going to require budget lines of government. And I think these results and this evidence give us a platform to be able to do that. Thank you very much for participating in this webinar, and I hope that we can have a good discussion afterwards. Thank you.
Great. Thank you, Lola. And thanks to David, and thank you to the HFG team for hosting this webinar on such an important topic. So we heard at the beginning of the webinar from David about some of the really critical findings from the marshaling the evidence work with, I think, a special focus on the accountability work stream. And then Lola took us further to say, okay, well then what do we do about that as different development partners, whether we be civil society, donors, researchers, whoever we might be. What we wanted to do before getting into the discussion is to actually turn to some of the practical implications. So, we have all of this evidence that has been generated from the Marshaling the Evidence initiative. And so I think the next obvious question beyond the call to action is to say, well, what do we do with this? What are the practical implications of this evidence? And to talk through this, I wanted to share a few insights from a project that I've been very involved in the past several years called the Transparency for Development Project, or T4d, which both tries to generate new evidence about what works in accountability, but also has benefited greatly from evidence of the type that is consolidated and analyzed in the Marshaling the Evidence work. So next slide, please. So just a little bit about the T4d project before getting into some of what we're learning and some of how we've used the evidence. This project at its core is a research project, and the goal is to generate rigorous comparative evidence on whether and how a well-designed transparency and accountability intervention can improve health outcomes. This is something that R4D, Results for Development, has been working on for the last several years with the Harvard Kennedy School and several partners in Indonesia, Tanzania, Ghana, Malawi, and Sierra Leone. And it has several key components to this research. Part of this was designing a new accountability intervention, which I'll talk a little bit about. And then undertaking a mixed methods evaluation, which includes a randomized control trial. So we will have rigorous evidence about whether this works, but also this really important qualitative evaluation that helps us understand why it might work, why it doesn't, the role of context and the role of different mechanisms in accountability to improve health. And then finally, we're undertaking a second phase that looks at testing additional questions related to accountability and health in 3 additional countries. Now, as I said when I introduced this, this is a project that's about generating evidence, but before we even really started this work, one of the things we wanted to do was look at the fact that the evidence around accountability and health has been very mixed. And so we wanted to really use that evidence in a way that could help us design a new type of accountability intervention that had more of a chance of success. So I want to talk a little bit about, what we learned from that process, what we did, but also additional evidence that's coming out that, could be helpful, especially in linking with the Marshaling the Evidence work to help civil society and others continue to improve the effectiveness of accountability for health. Next slide, please. So the first thing I want to talk about is this idea of multiple techniques and mutual accountability, which were themes that came out of David's and Lola's presentations as well. a lot of the traditional accountability work, particularly social accountability work, has focused on really having citizens and communities take one type of accountability technique. And one of the pieces of evidence that came out of this project, marshaling the evidence, was that that's not actually the best way to do things. That, there's better ways by taking a sandwich approach or bringing in multiple different techniques to accountability. And in the T4d Project, even in this pretty localized set of interventions, we found that this absolutely held true. When you design an intervention, an accountability intervention that provides options to community members about what type of accountability they want to undertake, they actually use that openness to really address different contextual factors and different things that they might think work best in accountability for health. So a few things that came out of our early analysis. First of all, communities in both Tanzania and Indonesia, when given the opportunity to design different types of accountability for action, undertook very, very diverse actions. So in Indonesia, we saw in every community there was an average of about 7 different types of actions that were undertaken. In Tanzania, it was a little bit lower, 4. But what we did see was that there was a real diversity in approaches from an accountability perspective, and these range from advocating for reform, community socialization around health problems, and direct work on facility improvement. I think another interesting point that came out of our work is that the contestational approaches that communities took were actually quite rare, which is interesting because I think for accountability, we often think of this sort of protesting negative interaction, but actually what we saw was that communities often wanted to engage in a very collaborative way with stakeholders, whether they be service providers, government officials, or others. And then they used contestational approaches when those things didn't work. So having these multiple techniques really worked to the advantage of communities. Next slide, please. Another theme that came out of both David's and Lola's presentation was the importance of civil society input to tailor to context. So much like we left the intervention open to different types of accountability actions, we also decided to design this accountability intervention to allow communities to decide what types of health problems they want to focus on. And this was, again, based on a very large set of evidence that we reviewed that said that, in some cases, you are going to see that, say, health worker absenteeism is the biggest problem, but in other cases, it could be financing, or it could be, cost, or it could be access. So what we wanted to do was design this in such a way that communities had opportunities to figure out what were the big health problems that they wanted to focus on and tailor their work to the context where they were working. And we saw that that really paid off. Communities selected a very wide range of different health problems that they wanted to prioritize, including things like community knowledge, family support, provider effort and attitude, cost, and a range of other issues. And this really varied quite widely across all 5 of the countries, even within a particular region in a country. We also saw that communities really tailored their accountability action targets. So rather than saying we're always going to go for health providers or we're always going to go to village government, we actually saw that in some cases communities even took their actions up to the sub-district level or the district level. Rather than saying that there was a one-size-fits-all solution, they decided to undertake different types of actions that they thought would be successful. Next slide. And then finally, and this was something Lola touched on at the end, there's this really important piece about how we integrate social accountability into the system more widely. And I think a big reason that we think this is critical is because it really helps to build sustainable and consistent local dialogue around health problems. What we've seen from the T4d Project so far is that, even without financial resources that are put into communities, when you do these sorts of accountability programs, if they're designed in the right way, you do see vast participation, consistent dialogue, and increases in empowerment among community members that are involved in the program. And this was something we observed over the entire duration of the project. I mentioned at the beginning about our phase 2 work, which actually brings in a new component of work where we're creating these spaces for community members to engage with district-level health officials who they may not otherwise have access to. And we've seen really promising results from that as well. We're currently analyzing our data, but what we're seeing is that it's allowing communities to engage with people who have power and are oftentimes champions for improving problems at the community level, but may not be aware of those problems until the communities come to them. Next slide. So this is really just a recap of what I've already shared, and I want to make sure that we have time for questions and discussion as well. But, you know, just to conclude, I think one of the things that's really valuable about this marshaling the evidence work is that it's not only taking evidence that is out there that all of us should be using in our practice and our future research, but it's also pulling out these calls to actions that can be used in a really practical way. And we found that, you know, even with this one example of the T4d Project, ways to integrate existing evidence to improve the effectiveness of this type of work in governance and health, but also to help answer new questions that may come up around the effectiveness of accountability and governance work to improve health. Thank you.
Thank you very much. That was great. We'd now like to have some questions and answers. Please send in your questions using the question and answer function on the WebEx, and then we'll put them to the panelists. Whilst we're waiting for questions to come in, we have one clarifying question for David. In your presentation, David, you talked about political settlement, and I wonder if you can just clarify that. And perhaps you could also provide a response to another question about you work across sectors, not just in the health sector. So could you say a little bit about what's unique to health around in this area, and where could the health sector learn from other sectors? David, over to you.
Thanks, Bob. I'll try and tackle the first one first, because the second one is a big question. So in terms of political settlements, this is something that comes out of some literature. Probably the most approachable bits to read have been from the Effective States and Institutional Development Program in the UK. And it's basically just a term for the understanding at a broader level of kind of what types of things are going to be acceptable for the various generally elites running the country, and kind of what type of space that leaves underneath it. And so it can be more you know, inclusive or exclusive. It can be more kind of contested. It can incorporate kind of patronage politics. It's very broad and big picture, but it helps us have a terminology to describe why you know, dealing with leakages in a drug supply chain in Uganda and Malawi might be very different, or even to Courtney's point, in northern and southern Malawi, you know, based on something that has nothing to do with the drugs or the drug supply chain, but has to do with the place in which that's becoming a problem, the expectations people have, you know, how civil service is organized and things like that. So it's kind of a shorthand for some bigger picture landscape within which the accountability work is nested. In terms of what makes the health sector distinctive, as well as where there can be learning, I love that question, because I think working cross-sectorally, I'm learning all the time. Some of the things that make the health sector distinctive, I think, as a sector, health tends to have you know, quite a bit of data and quite a bit of you know, history to be able to look at trends, and a lot of that is you know, not just to specific projects and programs and efforts, but kind of data about changes in a country context. I think this enables us to ask a lot more questions around what's going on in something like an accountability effort. I think for better or for worse, there are some, you know, and this is variable within the sector, but there are things in health where it just takes a long time to bear fruit, and it's very hard to tell, right? I mean, if somebody has, you know, replaced some of the, stockouts are easy to see, but if somebody has replaced some of the active ingredient in drugs somewhere with something that works less often or something like that, it's a little bit harder to identify for citizens. So there's some limits to accountability. Pregnant women can tell if they're being treated with respect, but they can't necessarily tell if, their infant got vaccinations on the right schedule or got the right vitamins or was given the right care when they presented as sick in different ways. And so there are some constraints around accountability within the characteristics of the health service. Another thing that I think is distinctive about the sector and can be quite useful is that there are these efforts to work on issues of quality in a vertical way within the system. You have a lot of effort spent on kind of supportive supervision and things like that that create some entry points to be able to, to Courtney's point, kind of have communities link with people trying to work on health and say, we'd like to help you do it better. We'd like to understand what your challenges are. We'd like to help you, and lay the groundwork for later holding folks accountable to those kind of agreed mutual expectations. And I think there's less infrastructure for that in other sectors. You don't see very much, by comparison in education, for example, the equivalent of a supportive supervision visit for teachers. It happens sometimes, but it's less robust of a system. And so I think that's something that can be built on really usefully by thinking through the different levels of the health system and where there might be, allies who can be part of an effort toward reform, even if for them it's just carrying out their duties more effectively or getting to better standards of quality or something like that. It links with accountability. And in terms of lessons from other sectors, I think I would point to some of the work, at least within USAID, on food security and kind of some of it's more in the policy realm, but there's been some interesting efforts in kind of supporting that and thinking about the institutional architecture for policy making and kind of how does that change and what type of efforts make the system itself more inclusive so that accountability is not limited to point of service interventions, but kind of also deeper efforts of integrating citizen voice into broader programming. We've also seen some success in different sectors liaising with DRG as a sector around things like getting parliaments involved. Too often in our conceptions of accountability, nobody would look at the Public Health Committee of Parliament, but they formally and oftentimes in actuality can play a significant role in accountability. If we can find ways to engage with some of the other stakeholders in the wider governance system. So I think there are some good lessons to learn from some of the collaborative efforts, and my team is trying to document some examples and case studies, and it's certainly something USAID is thinking more about as we kind of update our guidance and think more about self-reliance and sustainability.
David, thank you very much. Question to Courtney. Can you say which part of the Ministry of Health is best able and motivated to respond and push for accountability measures to be introduced?
Sure, that's a great question, and I'm not sure that I have the full answer. But there's I think two factors in particular that I think are important. One that's been highlighted in the T4d work, and one that actually came out quite a bit in a number of the marshaling the evidence reports. So the first is, is there a particular mechanism that actually needs to be put into place just to have accountability work at all? And this is something that came out to me in the marshaling the evidence reports, in particular, I think the PFM report. Sometimes for accountability, you actually need a certain type of infrastructure in place for it to work. So I think, for example, some of the really exciting new innovations in e-procurement or, open data portals, things like that, where, without those in place, it's really going to be difficult to achieve accountability. For that, I mean, I think there's very specific people in the Ministry of Health or, you know, potential allies through the open government community that can be really supportive and helpful in getting those in place. And I'd be happy to share some examples of that. But, you know, that sort of pitfall, I think, does require very specific people and specific roles within the MOH or other parts of government. You know, the other factor I would say is actually if it's less of an issue of the right infrastructure being in place, but more of an issue of political will, what we've seen in T4d is it's actually less important who the person is or even the particular power or responsibilities they have within the health system. What's more important is whether they're a true champion and actually want to improve and bring in citizen feedback into their work. So just to give an example, you know, I talked about this phase 2 work we're doing in Ghana, Malawi, and Sierra Leone. What we did in each of those countries with our local civil society organization partners was we selected different government champions at the district level who they thought would be, you know, the most kind of powerful allies for community members. And those ended up looking very different across the 3 countries. In Malawi, it was actually traditional leaders. In Ghana, one of the main government champions was actually the presiding member of the district parliament. And in Sierra Leone, it was more the traditional district health officer. And despite the fact that those 3 individuals all have very different roles in the system, because they had a very clear enthusiasm and commitment to bringing in citizen voices, we found that they were able to kind of use different strategies to actually build in these feedback loops and push for accountability. So that may be more applicable at the local or at least the subnational level, but you know that's one of the interesting things that we've seen from T4d is that it's less about the specific role or responsibility. It's more about finding that individual who really has the commitment for this, and then they can kind of figure out how do they make this work in the system.
Courtney, thank you. We have another question in, and this is for, I think, best for Lola. Can you say a little bit more about the power dynamics, particularly at the service provision level, and in particular, in the various experiments that you've seen, do you see citizens having been given options about where they get their services? Lola, do we have you? No. Okay, I'm having trouble getting through to Lola. So maybe, David, could I, we'll come back to that when we have Lola back online. We have another question. So that your slide about the iceberg was great. Did you really, in your work, did you really get into the why? And can you give examples of the responses to that?
Sure, and thanks. I would say so that we did not really heavily get into the why, but I think it does come back to you know, both what Courtney just said in terms of identifying the reformists with political will, as well as kind of the question of the, you know, thinking of people as widgets in the health system and not seeing the full kind of web of identities that they have. Some of the good examples and some of the things that we'd heard from, you know, case examples, what built up accountability over the health system was something other than just that. So I'm trying to remember, I believe one of our key informants, speaking from the Guatemala context, was talking about some effort to organize, you know, indigenous, you know, Guatemalans to kind of secure more of their rights that included health. And the energy and the power behind their engagement was around that sense of identity and getting a fair share. And so this had questions of, you know, access and equity and other outcomes in terms of health. And they were working on accountability to those commitments. But kind of who was in that coalition were not necessarily people whose top of the pyramid goal was ensure better health outcomes or better health coverage or even better health governance. It was really get a fair shake for our people. And so I think that type of thing is something where, from a donor perspective, sometimes we want there to be an effort built around, we want citizens to check for these two issues because that's what my funding's about and that's what we're working on. And a lot of the successful examples, the coalitions were diverse. The people in it may have had different motivations themselves. There were also some examples given where kind of the legitimacy that different interlocutors had was tied to the roles they played, and kind of some of the way that social accountability would work in one country context and not another sometimes had to do with some of the soft relationships between people, the role of indigenous chiefs or something like that. So I would say there wasn't a lot of focus and there wasn't experimentation around let's try different whys and see how that matters. But I think sometimes without us being aware of it, particularly from the donor side, we can just expect that what we're trying to accomplish, if we can find people who want to work with us to accomplish that, we must all be pulling the same way to get to the same destination. And we maybe miss some opportunities or have some friction in how we work with groups. There's also from the DRG sector a lot of research, and I would highly commend some work that Carnegie did, speaking to a bunch of civil society organizations that work on accountability in all sectors around how do they navigate their political contexts and maintain their legitimacy. And there can be an issue where if they're just seen as carrying out donor wishes, even if it's in accountability for a relatively consensus thing like better health outcomes, it can lead to the perception that they're not really authentic civil society and that they just are a tool of a donor effort to make something happen. And then if you see some of the health services, like for example, for certain populations around HIV, where maybe men who have sex with men or drug users are criminalized in the context, there can be problems if the civil society that want to work on that and want accountability around something like that are perceived as just tools of donors. So I think for a number of reasons, we should be more aware of the different whys that people bring to the table, even though that was not something that a lot of the research specifically studied.
David, thanks very much. Unfortunately, we have come to the end of the hour, so we should probably finish there. So I'd just like to end by, first of all, thanking the speakers for their time and for and for those who provided questions. Again, thanking to USAID and WHO who spearheaded this work a couple of years ago. And just to remind everybody that we do have the reports from the working groups on the websites, and we can see that here, and the video for this will be circulated and be available later. So again, thanks very much. It's been very stimulating, very interesting, and we look forward to Lola and colleagues in the civil society networks taking these messages to a higher level to have the impact that they deserve. So again, thank you very much.